The first person we want to introduce for you is a personal friend and an idol of my daughter's. Dr. Olufunmilayo I Olopade is an American Cancer Society professor. She also is the Walter L. Palmer Distinguished Service Professor of Medicine at the University of Chicago, Director of the Center for Global Health, Associate Dean for Global Health, Director of the Center for Clinical Cancer Genetics. She is a former MacArthur Genius Award winner, and you're going to find out she is a force of nature and a force in oncology.
It's really wonderful to be here, and I want to thank the organizers for putting together a fantastic event. This morning was absolutely marvelous, and I want to thank you for coming back from lunch to hear about cancer, the dreaded C word. Well, let me tell you that based on the amount of success and the progress we have made in getting to the genetic basis of cancer, I'm really, really optimistic that cancer is going to become one of those chronic diseases, like you get arthritis, you take Advil, and you keep going on with your exercises. That we are going to make it into a chronic disease that will not prevent any of you from living to be 140. How many of you are going to sign up for that? I will. So, genomics is really helping us to accelerate progress at a rate more than we've ever imagined. And now, we can use genomic medicine, number one, to plan what kind of baby we want to have. And if you look at what you have on the slide there, we talk about, even before you are born, that there's some things that can be programmed to either increase your risk for breast cancer or lower your risk for cancer. But we are not using all the tools we can be using right now to prevent cancer. And that's why I think if we wait till 50 to begin to use genomics to think about cancer, it's probably too late. We can do much better than that. Imagine a future where we are now is using genomics to diagnose cancer, to assign treatment. We can even use genomics now if somebody has a sudden death, right? You want to know why that person died suddenly? You can figure out whether, in fact, it was a mutation that caused them to have sudden death. So their children will never have to have that same fate. So that's where genomics is going with cancer. Now, let me give you Genomics 101. Sometimes we talk about germline. That is, it's this mutation. As you're all sitting down there, we're all having mutations, right? But what happens is our physiology is so perfect that those mutations are squashed. They don't progress. However, occasionally, you're born with a mutation or you acquire a mutation and then it gets passed on. If that mutation is in the egg or is in the sperm, then it gets passed on to the offspring, and that offspring, it doesn't matter whether they're male or female, they can pass it on to their children. This is why whenever my colleagues ask, did your mother have breast cancer? I would say, did you ask about their father? Don't always blame the mother for everything. So that's what germline is about. It can come from both sides of the family. When it's a somatic mutations, it's really something that happens by chance, and it arises in any cell in the body, and it can get passed on. So why is this important? BRCA1 is a perfect example of a gene that we discovered as far back as 1994, and now we test for it in the clinic because we know it will cause women to have early onset breast cancer. If they have breast cancer, it will increase their risk of getting a second breast cancer. And guess what? It will also increase the risk of ovarian cancer. And for the last 20 years, we've been working on that. BRCA1 was the first gene. BRCA2 came along. And we know that BRCA2 also will cause breast cancer. It also causes male breast cancer. Now we're discovering almost the most lethal prostate cancers. are related to BRCA2 mutation. So now, all of a sudden, the men are getting excited about BRCA2. Why is that the case? Because we know that the more genomic analysis we do, looking at tumors, the more we're finding that these genes, BRCA1 and BRCA2, and other genes that are involved in the DNA repair pathways, they can increase your risk for getting cancer. So pancreatic cancer, melanoma, those of you who are golfers, gastric cancer, laryngeal head and neck cancers, hematologic malignancies, we're suddenly finding these genes that we thought were only involved in breast and ovarian cancer in other cancers. And that's because we now have the tools to do lots of testing. So in June 2013, the Supreme Court, in a unanimous decision, decided that no one should be able to patent genes, right? As a result of that, everybody now can order a genetic test. Many companies now are beginning to offer genetic testing for anything related to cancer. The Angelina Jolie effect was when she came out and said, I have a BRCA1 mutation. A number of people came forward wanting to have testing. But it's not celebrities that really have to tell us about these genes, because all of us have genes. All of us can inherit a mutated gene, and all of us need to know about what is important, which is what is my risk of getting cancer. If you haven't asked your doctor about that, go back home and ask your doctor. Because what is important now is that we need to do risk assessment so we can do tailored screening, risk reduction strategies, and now we actually know what to do because we have studied it and we know what works. If somebody has cancer, we're now using that information to develop targeted treatment options. And that's how we came about saying that one size doesn't fit all anymore. We have to customize what we do for our patients based on their genomic analysis. Because if we're talking about breast cancer, I'm an oncologist that treats patients. When I see a patient with a mutation, I want to know how to help them make treatment decisions. I want to help their family members talk about what they should do after they have survived cancer. And so all of these things are coming on, and we can do better than just wait to get cancer. So there is an example of a magnetic resonance imaging of the breast of one of the patients that I identified in my clinic. You can see the reason why we have arguments about when do you get a mammogram, do you even get a mammogram, is because sometimes our breasts are not all the same. Some have very dense breasts, some have very fatty breasts. And as a result of that, we can't tell every woman, go and get a mammogram when you get to 40 or 50. We don't even know what age to start. So this is why precision medicine, precision risk prediction is a wave of the future. This woman would never have found this tiny cancer, but because we can do 3D imaging with an MRI, the American Cancer Society actually said, if you're a mutation carrier, don't wait to get a mammogram at 40, go on and get MRI. And that's why we were able to find that cancer early. So this is the end of mobile mammography for the American Cancer Society. We're in the dawn of a new era because we know that we need to do precision medicine. We need to collect lots of data. And we're now at the inflection point where I'm talking about genomics, but my colleagues are going to tell you about the microbiome. They're going to talk about exposures, behaviors, and now we're going to have clinical tests that are going to be able to really get us to that one person for us to be able to tell them what they need, when they need it, and how they should get it. So how do we get there? Well, the cancer genome is the most expensive experiment the National Cancer Institute has done lately. And what they did was, let's get all the tumors out there. Let's sequence all of them. 33 different tumor types, 10 rare cancers, 11,000 patients. And we have more than 7 different data types with 2.5 petabytes of data. And those data are available for any scientist to go out there and try to make meaning of the science. Not only is a Cancer Genome Project occurring, we actually have an International Cancer Genome Consortium doing pan-cancer analysis of whole genomes. And these are researchers from all over the world, because we know that we cannot solve the problem of cancer alone. Doing reduction is science. We now want to, the physicists have all the equation, so why don't we bring them in and have them help us do this? So that's where we are, where if you now ask me about what do I know about breast cancer mutations, this is now presented to me in a graphical forms with lots and lots of beautiful colors. So I've always loved physics, and that's why the convergence of physics, engineering into biology is going to get us to where we need to get to, because we can look at the signature of exposure. Why did this person get breast cancer? With the same data, I can find what genes are driving this person's cancer, so I can put a targeted therapy for that individual. So genomic testing are allowing us to have targeted therapies. Some of the DNA mutations that lead to cancer are also now drugs that we can test. 4 drugs targeting BRCA-associated breast cancers. Genomic molecular testing of the cancer tissue, which is the somatic mutations, can reveal targeted therapies. And that's really why we're excited that the future of oncology is actually not about building big pathology departments. I kid my pathologists that, you know what, they're going to be out of a job very soon. Because all we want to do is get a liquid biopsy, and then in the liquid biopsy, I'll have the information I need to treat the patient. And it doesn't matter what community that patient is living in. I know what drug to use, and I'll just send a drone to drop the drug for the patient. So why do we need hospitals when we can actually do this on a massive scale, keeping patients in their communities and also having information that go way beyond the academic medical centers? So these are all happening now. It will help us get treatment strategy right. It will help us get cancer screening, early intervention right. We want to develop find localized cancer. We want to know whether a patient who has just had surgery actually has risk of dissemination and detection of recurrence. Because if we have the right drugs and we can pick the recurrences early, then maybe we can treat it even much more effectively. So this is really where we are going. And then for those who have refractory cancer, there was a paper in the New England Journal this week where there was a very rare mutation. Very few people had it. And they had a global study to find anyone with that rare mutation. The study was done on time. The patients who had the mutation got the right drug at the right time. And it didn't matter where they lived. So here's where we're going with oncology. We need to begin to do clinical trials for all of us, right? It's going to be precision oncology, cutting-edge research that's multidisciplinary. We're going to be thinking about biospecimen collection and annotation, and then we're going to do big data science. We're going to have artificial intelligence that will tell doctors what to do. I do believe that 10 years from now, there will be no oncologists like me running around. So this is where we are going to not only be able to get the right drug for the right patient at the right time, but we're also going to be able to engage in a global movement to shorten the time that we get our clinical trials approved, because if we can do efficient patient recruitment, we have improved clinical trial participation, then we won't have the very high costs to oncology drugs that's preventing most people from getting access to care. So genomics can help us with preventative care. It can help us with early detection. And if I do genomics research and not talk about social justice, then I'm really a useless geneticist. We have to have universal access to health insurance because your genes were not your fault, right? And we have to be in solidarity with everybody. So the promise of genomics is going to be revolutionizing how we take care of cancer patients, but we have to fight for universal health insurance so that everybody, no matter where they are, can gain access to the best cares at the right time and using the right drugs. Thank you.